Hello, everyone, and thanks for tuning in to the Innovate Health Yale webinar on mobile technology and health disparities in low-income communities in the United States. The webinar will begin after this brief announcement. Before we get started, we have a quick housekeeping announcement in regards to one-on-one questions and answer functionality. First, this webinar is designed to be an open, interactive conversation, and participants are designed to submit their questions via the Q&A function in the menu bar at the top of your screen at any point during the event. Due to time constraints, we will not be able to address every question submitted today, and we'll answer as many as possible. Note that this webinar is being recorded and will be made available online. Many thanks for your attention. Now, we are pleased to announce and welcome Dr. Ayesha Khalid, Clinical Director of the Center for Biomedical and Interventional Technology at Yale School of Medicine.
Hi, thank you so much, Ani. Thank you, and welcome to everyone on the webinar today. I want to thank my panelists that are really making this successful and hopefully an enjoyable experience. And most importantly, I want to encourage everyone, we're going to have plenty of time for questions, so please, this is the time and place to get all of that answered. So these are the folks that are most passionate around digital health and health IT solutions. I'm going to start with Dr. Natalie Levy, Assistant Professor at the New York University School of Medicine. She is focusing both on rolling out at the Bellevue Hospital a diabetes program and is also in charge of something known as mighty texting. And we'll talk a lot about doing that innovation at scale. And next, I want to introduce Bobby Jefferson, who's the Chief Technology Officer at DAI Global Health. He focuses on tech-enabled solutions and services and has a lot of experience around the world on how these things can be deployed at scale. Next, I want to focus on Dr. Rafael Pérez-Escamilla, who's a professor of epidemiology and public health, director of the Office of Public Health Practice and the Global Health Concentration at the Yale School of Public Health, so right here at Yale University. And he has been really, and we'll talk a little bit about this, passionate about food security research, including being able to get fresh produce in the local community using tech-enabled tools and improving community nutrition, and then also has been instrumental in leading a health IT program to improve the ability to access and support breastfeeding programs. And last but not least, a good friend of mine, Dr. Maulik Majmudar, who is Associate Director of the Healthcare Transformation Lab at the Massachusetts General Hospital and has had quite a bit of experience both as a practicing cardiologist using health IT solutions in his own practice, but also having served as Chief Clinical Officer of a startup in Cambridge. He is here to talk from the point of view of how do you see these ventures from an early stage and scale them up. So without any further ado, I want to thank everyone for joining, and we'll go ahead and get started. So to lead it off, Bobby, if you can tell us a little bit about what are some of the biggest trends in tech solutions that are being developed now to address access inequality. And I guess even before that, what does access inequality mean for you?
Great, thank you for allowing me to answer and respond. So firstly, it seems as if there's a disparity between the access of both technology and the cost of that technology to those who need it the most. And it happens not just in the US, but it also happens globally, because we know that a $500 smartphone isn't easily accessible to everyone. So doing solutions at scale on expensive devices can cause issues. But in terms of the technology trends, I'm often reminded of the Gartner height curve, in which many of the technologies start off very much on the hype cycle and then fall off into the trough of delusionment. So as part of the work I do at DAI, we do investment to startup companies. And so I can tell you that companies, the technologies that many of these companies are putting forth are around telemedicine and machine learning and point of care diagnostics, big data analytics, of course, and one of my favorite that's really hot at the moment. Again, it's in the beginning part of that hype curve is blockchains. So using blockchain for medical records, patient identity, that just seems to be the next wave of technology trends at the moment. The biggest trend overall, though, and I'm pleased to say I've seen, is the rise of social entrepreneurs. People who are willing, students, graduate students, others who are willing to contribute solutions to help the communities. So being able to come up with ideas as social entrepreneurs, I see has been one of the longest and best trends so far.
Thank you so much, Bobby. That's excellent. So that gets us started, and I didn't know anything about blockchain, so that's very interesting. And we'll come back to some of what you said around investments and what types of investments. We'll certainly talk a little bit about that for our participants, what investors look for, particularly in social entrepreneurship efforts. So I think now what I'll do is we'll go ahead and move to the panelists and have a few of you talk about success stories. And, you know, a lot of times we start with the challenges or why things won't work. And we particularly do that in healthcare. We tend to be very conservative in terms of changing the paradigm. So we wanted to flip that a little bit and say, can each of you share a little bit of where either in a specific instance or at scale you've seen success using a health IT or a digital health tool, and particularly to access populations that have been unable to access these tools before. So Natalie, if you want to go ahead and start with that, thank you.
Sure, thanks. So thanks for having me. I appreciate being part of the panel. Hi, I'm Natalie Levy from NYU Bellevue. So let's see, I'd like to tell you about the program that we've had a lot of success with. To start, I work at Bellevue Hospital. It's a public hospital in New York City. We take, primarily we take care of patients that are underserved. We have about 6,000 patients that have diabetes at our hospital, and many of them have poorly controlled disease. In general, patients, when they start on insulin, will take insulin at night, and then they check their sugar in the morning, and they have to write that numbers down, and at some point those numbers need to be shown to a clinician. And classically, patients have to come in person to show their blood glucose logs to a clinician who gives them advice on how to adjust their insulin. This is extremely challenging for many of our patients. For our patients that do work, most of them do not have jobs that have sick days. So when they don't work, they at minimum risk not being paid, and at maximum they often risk losing their jobs because they're not going to work. Coming to Bellevue is, it's like many public hospitals, not a quick something you can do on your way to work. So for our patients that don't work, a lot of them have children or elderly parents in their care, and again, it's really tough for them to get to in-person visits. So we wanted to know if we could do this better. Certainly patients needed to check their blood sugar numbers. They had to get the information to the clinician, but did they have to come in person to do that? So we designed a program that we want called MIGHTY. It stands for the Mobile Insulin Titration Intervention. Call it MIGHTY. And our 3 goals for MIGHTY were that we wanted to be clinically effective, of course. We wanted to be very patient-centered. So everyone talks about the patient-centered medical home. We really wanted to design a very patient-centered program, and we wanted to be very accessible. So we designed it around basic technology. So for MIGHTY, we have access to a secure web platform that can text patients. So patients that enroll in MIGHTY, a doctor might say it's time to start you on insulin or to change your dose. Patients will be enrolled on this secure web platform, which will text them every morning, ask them one very simple question. What was your fasting blood sugar this morning? At the moment, it can be sent in English and Spanish. Very importantly, for anyone designing a program, you have to have text messaging programs that can access phones like Medicaid phones or prepaid phones. And every day, patients are sending us this information, answering the question of what was your blood sugar this morning. And then once a week, so they text every day, but then once a week on Thursdays, we call patients, and the nurse, basically the diabetes nurse or regular nurse, calls patients and uses an algorithm that I designed primarily, but with the support of my team, and gives advice about how to adjust their insulin. So it's a very basic program that's filling a need here at Bellevue for a lot of our patients that have poorly controlled diabetes and a lot of challenges coming to clinic in person. So I could go on about it, but I probably should stop there.
Perfect, perfect. So I love 2 things about that success story. And before we move on to Dr. Rafael, I love that it's simple and there's one thing that you ask. And then I also love that there's that blend of a phone call. I know patients really love when they hear from someone, to be able to ask their concerns. So let's have some of the other panelists chime in. So Rafael, you've mentioned a couple of things as we've been preparing where you've successfully seen health IT tools address inequality.
Yes, thank you very much, Ayesha, for having me. Greetings to all the web audience. So in 2011, the Institute of Medicine, which is now called the National Academy of Medicine, asked me to chair a national panel to advise the government on how to improve breastfeeding, protection, promotion, and support activities within the Supplemental Nutrition Program for Women, Infants, and Children, which is effectively known as the WIC program. It is a program that serves over half of the children born in our country and focuses on very low income families. And obviously it is totally overrepresented by minority groups, including Hispanics and African Americans. So soon after I returned from completing that activity, I communicated to my team that one of the top recommendations that was made as a result of that panel was to actually use much more the text messaging capabilities to supplement the toolbox that community health workers or breastfeeding peer counselors could have at their disposal to enhance the timeliness and the reach of their efforts. So in partnership with Nurit Harari, who at the time was a Robert Wood Johnson Clinical Scholar here at Yale, we developed the LATCH protocol, which stands for Lactation Advice Through Texting Can Help. And essentially what we did was to develop behavior change messages starting since pregnancy that would go out through an automated two-way text messaging platform. So initially they are automated, they started in pregnancy, and then they continued during the perinatal period and then the postpartum period all the way to 3 months postpartum. And as you can imagine, the messages had to be tailored to the specific needs in relationship to the planning and preparation for breastfeeding during pregnancy, and then to the common problems that women experience during the first days after birth, especially engorgement and sore nipples and issues related to the positioning of the baby, and then all the issues to returning to work and access to breast pumps. And I could go on and on, but the bottom line is that it was a very successful experience because it was two-way text messaging. So the automated messages obviously could receive a reply from the moms that went directly to their peer counselors, and then they would initiate an exchange to try to resolve the problems that they've had. We have completed 2 RCTs through randomized control trials to find out if the intervention works, and we conducted extensive process evaluations to actually see the technology, how it functioned, and how it was received by the audience. And what I can share with you, my doctoral student just defended her dissertation earlier today on this project, and essentially what she found was that the more problems were resolved through the two-way was that the moms were exclusive breastfeeding at 2 weeks postpartum. So it is a success story in the sense that the technology worked. We had an impact on behavior based on higher dosage of exposure to the text messages and the solutions to the problems that were encountered, and also in the sense that the vast majority of weak moms not only had cell phones with text messaging capabilities, but they are actually smartphones. So they were able to access the internet and all the links that we provided to them. So the good news is that really smartphones are becoming a very strong instrument to bring more equity in terms of access to information and the ability for low-income audiences to actually resolve breastfeeding problems that they're having. It was in 4 week clinics in Connecticut, and we're now in the process of having conversations with the state to see if this can be rolled out statewide. They are very interested. They were very involved with this project since day one, and we have presented this work to the UA in Washington, D.C., who are extremely interested in moving forward with a cost-effectiveness analysis of how much this would cost to be implemented nationwide. So far, so
Perfect.
good.
Wow, thank you. So I think your experience, there's a couple of threads I'll pick up, and then I'll move to Maulik to talk a little bit about success stories across the Healthcare Transformation Lab. I think there's, for me, 3 things that you highlighted that for the participants are critical. The first is that very tight episodic time frame of the baby is born, you're struggling with the breastfeeding, and a lot of times the drop-off rate is really high if you can't access a provider and information or lactation consultant. So, just that ability to get somebody to respond to your concerns. I think, again, the second thing you highlight that Natalie highlighted is that it's so specific. So for the people that are on the webinar that are thinking through health IT and digital health solutions, the specificity and the tighter the niche of the audience will actually allow you to have much higher and faster scale. And the third thing that you highlight, it's interesting, we'll come back to this later, Bobby, as we talk about integration with what types of tools, is that I find that even as I'm treating folks across all levels of income, the smartphone penetration is really high, at least in this country. And then I think if we think about it globally, and the smartphone is the most important tool, I think, in terms of providing that equity. So Maulik, we're going to jump to you, and bearing in mind that there's probably a wide audience on the call, but I know that some of the audience are young entrepreneurs or investors in health IT, digital health. What would you say to them in terms of success that you've seen? And then also you can bridge us into the challenges that you see that often happen where things fail. You're still muted, so we're going to assume you're saying brilliant things, but if you want to start from the top.
Can you hear me now?
Yes.
All right. Thanks, Ayesha, and thanks for having me. It's nice to be with the group of panelists here, and welcome to the students. So I think as you mentioned, you heard 2 success stories just now, which are very interesting in 2 different populations. And I feel like there are a few more of those success stories in the cardiovascular space as well. There's been a number of publications recently in large samples of populations where actually one specific example is in New Orleans at the Ochsner Clinic. They've used a similar technology as to use text messaging to manage people with high blood pressure. Again, very underserved population, and had fantastic results. And that was a randomized controlled trial that's just being published. So I think there are a number of examples of these, what's called digital tools and technologies that people are using to manage chronic diseases, and predominantly so in an underserved population. But one of the challenges I think I see is, even though the pilots and these RCTs are successful, we're not seeing this at scale just yet. And the question is, why not? And I think the smartphone statement you made is true. However, the data plans and all these other aspects that go into it is actually very disparate between socioeconomic groups, right? So if you look at the number of patients that access patient portals on electronic medical records, there's a huge disparity between who's actually accessing these portals. And if you talk about the challenges, one of the challenges I face a lot at Partners is integration with our electronic medical records. So for all of us to really see these pilots go to really massive scale, where it's really equitably distributed to all patients who should be eligible for these technologies, how do you actually create infrastructure to be able to handle the data on a continuous basis? Who's responsible for looking at this on a continuous basis? Is it the research group? Is it an operations group? Is it a physician? Is it a healthcare ancillary staff like a nurse practitioner? And I think having some of those processes really set up and well-defined will allow this technology to really scale, because I think the same model that you guys are using should be applied to all diseases, because it actually works really well. And I think the key questions for students in the audience is, how do you figure out a way to really work with the health system where you can create the infrastructure to be able to do this and distribute this well? I hope that answers some of the questions around some of the integration challenges, also responsibilities and liability around who's responsible for this, these sort of activities.
Yeah, I think what you've brought us to is, so I think really we're in the crux of the discussion now. And I think our last discussion point before we start taking questions, and then we can go ahead and respond to those, is how do we, in the face of provider engagement, consumer engagement, or patient engagement? So for example, if we take the breastfeeding, or we take the diabetes, we have a highly motivated mom. There's some indications and implications on the data plan, but then there's also the lactation consultant at the other end that's receiving that information. How can she quickly and easily from her smartphone device integrate that into the Epic system, which or any EHR system? But I'm picking that one. So let's say she's at Yale and she's using that, so that not only do you get credit, but you have documentation that you spoke with the patient. So I think that is a lot of the technologic challenges. I want us to think even broader. What are some of the other challenges from a socioeconomic standpoint? And if you guys want to comment a little bit on language and also on trust, I think those are two I find patients are surprised if I say you're going to get a text and this information is going to come on their phone. They almost don't view their phone as a healthcare tool, but they use it for almost everything else. So really we're talking about, can some of these digital solutions provide a mechanism for continuing to make it less inequality all the way around? And I think this is one that every panelist maybe should take a stab at, because I think you all bring different viewpoints. Bobby, if you want to start with this one.
Sure. So one of the challenges is around patient privacy. So being able to securely capture your biometric information, your information that you want to share on a secure portal, is still captured on your phone. And if you're under the age of 18, for example, there's these issues around informed consent and consent to the parents. So you're collecting information, collecting data, you're sharing it with the medical providers, who in the end hopefully will provide it to an Epic system or others. But one of the challenges that the patients face is it secure? Is it safe? Who else has access to my information, and how do I secure that? So we've seen this repeatedly as a challenge, and one way to address that is when the provider themselves are the ones who are directing or guiding patients as to different types of either mobile apps or solutions or something that they can use. It's very rare where you can collect your information independently and then provide it to your physician, primary physician, and then he automatically uses that. Right, there's this gap between information that's collected and the trust factor as well. So security, the trust factor that was mentioned earlier, are some of the challenges from the patient side to being able to have accessibility to these apps.
Natalie, if you want to comment a little bit about, what are the biggest barriers, I guess, to access right now that you see?
Sure. So for multiple, chronic diseases are tough. They require a lot of work from the patient, from the system over time. And there's many pieces to a diabetes puzzle, but this one area was an area where we thought we could make life a lot more convenient for our patients. I will say that at Bellevue, most of our patients, they usually have basic flip phones, or even when they have smartphones, they don't usually have data plans and they don't use a lot of apps. So even our patients that have smartphones, the main tool that they use on their smartphone is the phone, the voicemail, and the texting. So we designed our program around that. I want to mention about the trust and privacy. So basic SMS texts, they're unencrypted, so they come to phones. So we had to work with our hospital compliance officers to actually create a separate consent form that basically was titled Consent for the Transmission of Protected Health Information through Text Messages and Voicemails. Other facilities may not need to do something like that, and if it passes the common sense test, it may be something that can be incorporated. But for privacy issues, we had to come up with a separate consent form that we've translated into 13 languages and took a lot of work. In terms of trust, our patients really, we did a lot of not just quantitative feedback, but qualitative feedback for our program, and our patients really loved it. Their feedback was basically divided into 3 categories. Number one, they really appreciated the convenience of the program. I mean, truly appreciated the convenience. Secondly, they just felt very connected to the healthcare system and their doctors and their nurses. They felt like the program was just really looking out for them. And every time they got that text message, even though it was automated, they felt that we were like reaching through the phone, offering them support. And finally, I feel they felt very motivated. So patients would say, you know, I was falling asleep at night and I was in bed and I didn't take my insulin, but I got out of bed to take my insulin because I knew the next day I was going to have to text in my number, or I thought about what I ate the night before, the sugary drink that I didn't have or the ice cream I didn't have, because I knew I'd have to be accountable. So we actually didn't run into a lot of issues with trust. At Bellevue, the patients using this were primarily, most of our patients are Hispanic, some African American, some white. We started our program at Gouverneur Health Center, which has mostly Chinese patients that speak various Chinese dialects, and we're just starting our program there. And we are running into some cultural differences that we are working through. So privacy was an issue. We had to have a consent. Trust in the patients at our hospital, it didn't seem to be a challenge. They really loved the program.
Thank you, Natalie. So we'll continue, but I just wanted to say at this point in the webinar, certainly the participants, a webinar is an interesting form of communication because we can't see you, but we know you're there. We want you to type questions in into the queue, into the chat box, and then we'll go ahead and start putting them in a queue for us to respond to. And as participants are doing that, let's go ahead, Dr. Rafael, if you want to comment a little bit about, you know, what are the biggest barriers? So we've talked about trust, we've talked about privacy. What else do you see as sort of stopping the scaling that Maulik spoke about, which is a real problem?
Yeah, so in case of the breastfeeding peer counseling, trust was not at all an issue because this two-way text messaging system was totally tied to their breastfeeding peer counselors, an IBCLC that the weak moms knew well, they felt very comfortable with. So that was not at all the issue. For us, the big issue is that the platform creates a demand, creates an expectation that there is going to be a very rapid response when the help is needed. And unfortunately, the WIC program doesn't have enough funding to have full coverage with breastfeeding, peer counseling, IBCLC services. So sometimes if moms had an emergency, or I shouldn't say an emergency, but had an urgent question in terms of a feeding difficulty they were having, and it was Friday at 2 p.m., they would not get an answer maybe until Monday or even Tuesday. And it was sometimes too late. And obviously that didn't, that causes, you know, some concerns at the state level and the national level when we're saying if you want to scale this up, you really need to improve the level of investment in breastfeeding peer counselors and IBCLCs, or find a very efficient way of ensuring that there is always someone keeping an eye on the text messages that are coming from the clients, and that someone that is qualified can respond. So it is very important for the audience to understand that once you start engaging with this type of text messaging interventions or programs, you better be prepared to respond. Because if the response is not fast enough or it is not of good quality, obviously your clients are not going to be very happy with that. The second issue that we had, but that can be technologically improved very easily, was that sometimes it was not very clear to the patients which were the automated messages and which ones were actually real-time responses. So sometimes they would have a question, you know, I'm having my breasts are too full, I'm having a lot of pain, and then so they, just by coincidence, they could get a few minutes later an automated message, hey, good morning, how are you? Are you still breastfeeding your baby? And they would get confused, you know, as to whoa, boy, you know, I just asked you a question, I'm having a problem, and this is what you're answering me. But I know that is something that it can be worked out. So for us, those were, I would say, the two key recommendations that we are making for scaling up the system. You cannot scale up this system if there is not going to be enough personnel covering the demand created platform. And last, very quickly, I want to comment on Natalie's point, because I also do some diabetes work with Latinos and community health workers here. And, you know, she's totally right that in terms of the age group that we're talking about affected by diabetes, we cannot proceed the same way in terms of assuming how much they use or for what they use their iPhones or cell phones. But here, when it comes to breastfeeding, we're talking about relatively young women that are really very engaged, and they use apps. And actually, for many of them, you know, the smartphone is really their source for the family to access the internet. They don't have PCs, they don't buy laptops anymore. So the audience also has to take into account that they need to do a lot of formative research in terms of understanding the likelihood that the age group and ethnic group that they're targeting is actually engaging with the gadgets that they need to engage for your program to work.
Perfect, thank you. So that actually answers a lot of things and leads perfectly into one of the audience questions. So Maulik, if you can go ahead and answer, you know, what you think are the best mechanisms. And then Rosalinda Cortez asks, how do you see artificial intelligence impacting health access for underserved populations? And I think, Rafael, you set up this perfectly. So go ahead, Maulik.
Yeah, I was going to say that was, and I'm not on mute anymore. Oh, good. So that was actually perfect. I think one of the things you mentioned was this idea that the text messaging, the automated text messaging that went through was not very intelligent, and that caused some confusion. So I think there's two things where artificial intelligence can play a huge role. When we talk about access to care, one of the things all of us on the panel know here is with the Affordable Care Act and the huge number of people who are now insured, it's very, very difficult to get a timely appointment, either with the actual primary care physician or even a nurse practitioner. And these text messaging programs are great because it gives you instant access. So this idea of the patients being connected, even though they don't have to travel all the way to the clinic, is a huge one. But even with that, I think that what point was mentioned is that it's hard to scale that. Because if you did scale it, you would require so many resources, so many nurse practitioners and doctors to actually handle the inflow and outflow of these messages on a continuous basis for the large populations of patients with chronic diseases. So I think we absolutely need systems like artificial intelligence, machine learning to try to take these questions and develop automated responses that are really intelligent, with natural language processing and all these sophisticated tools to almost make it sound like it's from a human. And I think there are already startups in the space doing avatars. So it's not just even a text message, it's actually an avatar that speaks to you that feels like it's a nurse or a doctor from a hospital system. So all these sort of technologies can help make that interaction and dialogue almost as real in real time, which allows you to scale that one nurse practitioner or doctor to hundreds of patients. I think that is where you drive cost efficiency. So one of the things we didn't talk about in the challenges section is who pays for all these things, right? And we want to go into the payment cycle, but that is a question that comes up. If you try scaling into millions of patients, how do you actually accommodate the cost that goes with it if it's going to be a human interaction? So I think you need a AI sort of model to be able to do this at scale. I think that's a perfect way to address these issues.
Perfect, thank you. So next we're going to jump to Natalie. Dr. Levy, if you want to go ahead and answer the question, talk a little bit about the process for validating the efficacy of the system you're using. This came up earlier, Rafael mentioned it, but any trials comparing the hemoglobin A1C, and maybe you can broaden that a little bit to say, you know, what's needed for a digital health tool, because I don't think it's the same bar as we do for basic science research.
Sure. So thanks, Kevin. I saw your question asking about validating efficacy and issues surrounding reimbursement. So I'll talk about that like you just suggested. So we did publish, we had a grant from our CTSI, and we had a grant to look at in a randomized controlled trial, taking all patients that were referred to us. It was a small trial, it was a pilot, but taking patients that were referred to us who needed their insulin dose either initiated or titrated. And we basically flipped the coin and put them either in the MIGHTY program or usual care. It was published in JMIR. It was the Journal of Medical Internet Research. So if you just Google JMIR and then MIGHTY, M-I-T-I, we come up. We had a protocol paper and then a results paper. We have said from the beginning that even if this program was no better at controlling someone's, getting someone to their optimal insulin dose or A1C improvement, even if it was just the same, just as good as usual care, but much more convenient to patients and feasible and cost saving, that it would be a win. But in the end, our goal was to get patients to their proper insulin dose. And in our pilot program, patients that were randomized to the MIGHTY arm, I think it was about an 88% chance of reaching their optimal insulin dose. It's a 12-week program, and the 12 weeks. And our control arm was about 36, 37%. I think our control arm got better than usual care, to be honest, because a lot of times they were being seen already in our diabetes programs. But we currently have, we ourselves have an implementation grant, an Aetna Healthier World Challenge implementation grant to study the implementation of our program MIGHTY on a larger scale. And so I think we'll have some more data with time. I have a lot of really good preliminary data, but it's still preliminary. In terms of and other outcomes that we looked at feasibility. So we want to see, is this a program that would be acceptable to patients in a clinic-like hours? And 84% of our text messages were that asking what's your fasting blood sugar got a response. So we were really happy about that outcome, because I think in our clinic to have 84% response and compliance with anything is amazing. Nurses were able to reach patients relatively easily. I think it was like 91% of the time they reached patients on the first or second phone call or by leaving a voicemail that was responded to. And our other outcome was that patients save time and money. So most of our patients have about a $15 copay, which was obviously saved every time they had an interaction done remotely versus in person. And also time. We're not a local hospital. We're not a community hospital. We're in Manhattan, but most of our patients travel from other boroughs. And so patients had about 45 minutes of travel time each way, plus waiting room time. So it was effective, it was feasible, patients responded to the text messages, they saved time and co-pays, and I told you earlier about their satisfaction data. In terms of reimbursements, we actually do not bill the patients for this service. I think that the way with time the health system will be reimbursed is that these days there's a movement towards pay for productivity. Like the more patients you see, the more you get paid, as to pay for performance. So your health system is judged by various metrics, and one of them is how many patients can you have a hemoglobin A1C on every 6 months, and what percentage of your patients achieve an A1C less than a certain value. And I think the way the health systems that adopt programs like this, the way they are reimbursed is not so much on a patient-by-patient case, but the fact that they move the overall control of their patient population for the better.
Perfect. And that's actually a perfect lead-in. I'm going to have Bobby address the next question, and then I'm going to have Maulik take one of the ones that talks about some of the most important issues that students have. So the reason I said that's a perfect segue is because, of course, reimbursement is one way to look at it, but dollars saved to the health system is maybe the better way to look at it moving forward. So Bobby, somebody asks, the process for evaluating startups for potential funding is complex, but what are the most important factors that indicate that a venture has a higher chance of success? So this is, you know, what's the wild secret sauce if somebody on the call has a health, IT, or digital health tool, and no pressure, but they addressed it to you. So go ahead.
Sure. So just give you a rule of thumb for people who are on the investment side. They have a rule of thumb that every 10 startup companies they invest in, only one actually will scale up and be successful. So just to, you know, from the investment side, they're trying to seed as many good ideas. I was involved in another technology startup fund in which we were evaluating just concept papers, concept notes. We got a great idea, terrific idea to solve in digital health. Please send it in. So we received over 2,500 concepts that people wanted to fund at it was between $500,000 to $3 million level for each of those concepts and ideas. I can say from experience that's absolutely not the right way to do things. One of the things that I recommend for success is having an ability to demonstrate that your idea that you're doing actually solves a problem. I know that sounds very mundane, but there's many people who develop an application because it's cool or it's neat, but it doesn't solve a specific, either a chronic disease area or a infectious disease area or the justice community health workers. And now they're trying to find a problem to solve with their solution. So for example, one company that has a great idea and solution is Sproxo. They're in Boston. They have a great solution around counterfeit medications and medical drugs. The other one was a Yale finalist, Kinos. They colorize the disinfectant for Ebola workers to be able to disinfect each other and know where the disinfectant has occurred. So, you know, there's a number of solutions out there, but my recommendation truly is finding the solutions not just around savings, but things that demonstrate ROI, return of investment to the patients, having tremendous patient outcomes is really important, and then having something that really solves a problem. That tends to be where many of the these investment boards that I sit on say, yes, that's the place to invest funds and money.
Yeah, and I would say, you know, our next two questions, so where you ended, Bobby, about really solving a problem, I think the first viewer asks, what are our biggest global health needs that aren't being addressed by startups right now, and why not? And then I think the next one is a perfect lead-in, which is what is the most important issue for students building a mobile tech? So Maulik, if you want to talk a little bit about, you know, I think health IT, digital health is a vehicle for solving problems, but it is not necessarily the solution to a problem. If you want to parse that out a little bit and maybe answer these two questions.
Absolutely. And I think what I'll say may be a bit redundant to what Bobby said, but it actually is worth re-emphasizing. I think it's really critical. And I think Ayesha, what she mentioned is actually very important for you guys to know, is that digital health and technologies, whether it be mobile phones, smartphones, wearable sensors, they're all just tools that enable you to actually solve a problem. And I think that's fundamentally true. So the four things I'll tease out from what Bobby said is important is that, one, do I have a problem that's worth solving? And who am I solving it for? So identifying that what we call a customer or the end user is actually very, very critical. And then the second is, have I built something that somebody actually wants? Because you'd be surprised, there are a lot of times people build things that nobody actually wants. So be very, very close to your customer. Really understand what are they looking for? What are their pain points? Observe them in their home environments. Like, what are the things they are not recognizing as pain points that they're just working around? So I think that's probably the most critical thing. And then if you build something that people actually want, then somebody out there, they recognize the benefit, a tangible benefit, will be willing to pay for it. And in this model of social entrepreneurship, you don't have to worry about the payment as much, but still very critical in a social entrepreneurship business to still know how you're going to sustain yourself financially. So it's still equally critical to have a good business model, even if it's a non-for-profit, nonprofit, or for-profit. So it's just important. And then last but not least is, how do I scale that? Right? So how do you actually scale those technologies? We talked a lot about research projects and pilots, and now how do you scale it? And then after you answer those four, the question that comes up in digital health, which is unique to digital health, is your competitive advantage. So what is so unique about your solution as opposed to others? Because it's so easy to build an app or build a quick gadget. How do you differentiate yourself? And what's your competitive edge? And that's really always usually around, you actually really design the solution for your end user, your customer, and not just a technology widget. So then those are the critical components of what you should look for when you build a mobile tech solution. I can stop there, but I think if you want me to go to the global health one, we can have others answer.
Well, so, you know, I think, I'm going to make it specific because I'm imagining the participant at the other end, right? And we're saying things, and then here I am, I'm a student, I'm thinking to build it. So to answer, what are our biggest global health needs that aren't being addressed? I think those would be just our global health dilemmas, right? Why aren't they being addressed? You know, maybe we should talk a little bit, Maulik, if you just want to comment on the payment model at scale for some of these global health issues. What are some creative ways that you can either partner or provide it? Because we know that it's tough to get the providers or patients to pay for it.
Yeah, and I think the global health question is actually a really, really good one. I think there's a number of things that go into that question. Part of it's actually cultural, part of it's technology, and part of it's the payment, right? So the culture is, if you think about primary care and preventive care, in a lot of countries, the concept of primary care does not exist because people are really focused on symptomatic care, right? A lot of patients, at least in India that I'm familiar with, in China and other places, they only go to the physician once they actually experience a symptom. It's actually pretty advanced symptom. It's not even a minor symptom. So it's very difficult to introduce an entire concept of preventive medicine and preventive health when the culture is just not there. So I think that's a fundamental problem. The second problem, really big problem, is access to care. And within access, I'll say quality of care is actually equally relevant. There's no standardization, certification bodies in a lot of these countries that give you the kind of fundamental baseline quality that you expect from an American healthcare system. So that is a huge opportunity that people probably should solve and need to be solved. But it's not being solved today. Is how do you actually standardize high quality care across global health platforms? And then from a payment side, I think Ayesha, you're absolutely right. At least in India and majority of the other countries, is pay for service, right? It's pay out of pocket. So when people pay out of pocket, and U.S. is now recognizing this with high deductibles, people get very, very selective about when and how and where they seek care. In some ways, it actually poses challenges because people almost choose not to seek care because there's a high cost burden and there's financial implications of that. So trying to identify systems and building solutions and companies that try to do this in a cost-effective manner really is addressing a major global health need, which is to get to the patients who can't afford it. So I think that's a huge opportunity, actually.
Yeah, and I think to build on what Maulik was just saying, there are some companies that are unexpected players in this space. So, if you look at India and you look at some of the technology companies, a lot of them are investing in healthcare IT tools and have to Rafael's point earlier, the technologic prowess and ability to say, we can carry 1,000 people on this platform and be able to be responsive and maybe develop some AI. So for folks looking to develop solutions, it's not necessarily only partnering with the hospital or the provider or even the government. You might have some interest from some businesses in the area that are interested in spending the CSR dollars. So in India in particular, Maulik, I know you have example. You want to just talk about that, and that would maybe address the next.
Yeah, I think that's a fantastic point, this idea of CSR. So I think a lot of companies mandatorily in India have this thing called corporate social responsibility. And if you think about very atypical partners in healthcare solutions, telecommunications companies like Reliance in India or Vodafone, these companies that actually are in charge of the networks, the telecommunications channels, may actually partner with you to maybe provide the transaction costs for free in text messaging or data plans. And if that's a partnership you can create, all of a sudden, or you're building is actually the behavior change, the chronic disease management platform, and now worrying about the data feeds, the infrastructure cost, the wireless communication, or the data warehouses and servers. So I think that's a really good example how you can creatively partner up with companies where they feel like they have a responsibility from the government, they have to invest in that, and they can invest in your solution as a part of that. So I think we've done some work around that in India, and that's a good example.
So Rafael, just like Bobby had to answer the challenge of how to make yourself successful, the next viewer asks, what are the most important issues that require immediate, solutions for us? So, I wanted to pull that back a little bit and say, what are the pressing top 3 global health issues that you think need to be addressed with mobile tech solutions and have a gap that already exists?
Right. So I would say, as a maternal child nutritionist, that it is extremely important to enhance the toolbox that community health workers have in low-income countries to actually help address the very, very pressing issues of reducing infant mortality and maternal mortality and improving the quality of life of those individuals that, are trying to have access to better sanitation, hygiene, nutrition, vaccines, on and on and on. So to me, the biggest challenge that I would like to see resolved is how information technology, to some extent artificial intelligence, in combination with the community health workers, can actually be used to help them tailor much better the services and the provision of care to the needs of the different families. So, for example, when a community health worker gets trained in IMCI, Integrated Management of Childhood Illnesses protocols, I mean, they're supposed like to give like 50 different messages when they go to a household, and they are doing growth monitoring, and they're talking about diarrhea, and they're talking about vitamin A and breastfeeding and family planning and so on. But that is not efficient at all. What they really need is, based on the information that they are collecting, that the app, the toolbox, allows them to make a better decision as to what it is they should be focusing on during that visit. And at the same time, that all that information that is being used as a decision algorithm, as an intelligent decision algorithm, ends up also being data that gets deposited somewhere that it can be used for actually analyzing and tracking how is the process working, how much, you know, the algorithm is actually leading to improved survival rates and so on. So to me, you know, the whole topic of maternal child health care and nutrition programs in low-income countries, and the very central role that community health workers have played historically and will continue to play in the foreseeable future, to me is a very, very attractive, so to speak, market for social entrepreneurs that are interested in mobile health technologies.
Perfect. So we're going to go ahead and talk about 2 more points. And I see that there's another question about, you know, why is adoption so low? So in the United States, only 2% of hospital patients adopt mobile health apps, an even larger issue in lower income populations. Natalie, if you want to talk a little bit about, you know, we did success stories, right? So now we should talk about what are the critical reasons why folks aren't adopting the program that you've done. And if you also want to speak about the aspects of the actual tool that they love and don't love within that.
Sure. So for our particular program, it's adopted very well. I think of the patients that we've offered it to, there was one person that said they prefer to come to the clinic in person. But I guess I will start by saying that there are a lot of programs out there on mobile technology and apps to support patients with diabetes. But I work at a hospital that serves the underserved, and they just don't have, again, our patients just in general don't pay for data plans. A lot of times they don't go on the internet. They don't have apps. It's not part of their repertoire of what they use on their phone. Again, they use it to have phone calls, to text, and for voicemails. And when we were first looking about how we should design a program to help patients with diabetes, it was just very clear that what was out there were just not the types of programs that our patients were using. So we designed a program, really a very patient-centered program. One of you made the comment about when you're designing a program, the first thing you need to do is assess the need. And for myself, as the director of the diabetes program in primary care, I've spent years working with these patients. So I really had a good sense of what areas of diabetes care cannot be handled remotely and what areas could. So I think for us, we picked a very small sliver of diabetes care, but really high need. And by allowing patients the ability to have their insulin dose adjusted and interact with the healthcare system on a weekday basis, 5 out of 7 days of the week, just really filled a need. And the adoption of our program has been extremely high. Most patients that enroll in our program see it to completion.
Thank you, Natalie. And you know, we're out of time, so I'm going to go ahead and pass it to back to our host. But what I did want to mention is the panelists did want to bring up the point, Bobby in particular, that the data is valuable. And so whether the data travels on a smartphone or lives in an EHR, that is, for the folks building the health IT solutions, going to be very valuable, particularly in aggregated form, demonstrating trends. And who owns that data is going to be very, very important. And some of us believe the patients should own that data, but certainly as you're building a company, don't take it lightly that every text that went through in a two-way system meant something and showed something about the user. But I want to take this time to thank my panelists who got on late in the day to make sure and had absolute audio-visual success. And thank you again to folks for hosting. And last but not least, I think you'll mention this a little bit, Ani, but there are some opportunities for students. They can go ahead and apply for some prizes and money. We've got an Aetna Prize and other opportunities at Yale in order to build your venture. Thank you. Thank you again.
Thank you again, everyone, for joining us today. Dr. Ayesha, as you said, there are some opportunities if you're looking forward to kind of getting more involved with Innovate Health Yale. We do have the Aetna Foundation Seed Stage Grants, which is a $10,000 prize, the Innovate Health Yale Seed Stage Grant, which is another $10,000 prize. Both are due by mid-December. You also have the Aetna Foundation Prize for Health Equity Innovation, which is a $25,000 prize, and the Thorn Prize, which is a $25,000 prize as well. And these two last ones are given out in the spring. If you have any questions, please contact us or learn more about what we're doing at innovatehealth.yale.edu/prizes. Again, thank you guys all so much. On the right-hand side, feel free to tweet at us at IHYale and visit us again at innovatehealth.yale.edu. Thank you so much for your time, and everyone, please have a great day.